Yeah, we're live. All right, hi everybody, my name is Amber Brown and I'm the owner of Ivy League Tutoring and the head tutor here. So today I am glad to have you guys join us. This should be a really interactive session. We want to hear from you guys. We want to know where you live, where you're at, where you're in nursing school. So as we're kind of talking and we're going through, I want you to check in, let us know, where you're from. Let us know what endocrine issues you're having a hard time with. We're going to try to cover as many topics as we can today, but endocrine is hard for everybody and it's usually a pretty big struggle. So we're going to get through as much material as we can today. If you have any questions along the way, be sure to post them in the comments here. And then we have Casey's here working with us today. She's a CPR instructor for us and she is also a new nurse too. So she's here with us today and she's going to field some of those questions. So feel free to ask some questions and we'll try to get to them as soon as we can. So the first thing we're going to do here is we're going to go ahead and show you guys around Ivy League Tutoring and kind of give you a tour of the facility really quickly and tell you what we do here. So we are a tutoring school for nursing students. We're located in League City, Texas, which is about halfway between Houston and Galveston in Texas. We know we have a lot of people joining us from all over the United States and some other countries too. So we're really, really glad to have you guys. We don't just offer tutoring sessions here, though we do have a large facility that we're about to show you. We do Skype sessions for students all over the country and into Canada. We do tutoring sessions for LVN students, ADN, BSN, and MSN. We do tutoring sessions for every single course in nursing school to make sure that you're making the grades that you need to get the job that you need and to get prepped for your NCLEX. We also do NCLEX prep courses to get you ready to take your NCLEX. Those are 2 days where you can either come here into our facility if you're local or you can join us via Skype, Facebook message. We have all different kinds of ways that we can connect you and bring you into the session to get you prepared. We do tutoring sessions a little bit differently here. When most people think of tutoring, they bring in some questions and we answer them, but you'll see pretty quickly that that's not typically how we do things here. I'm jumping around from board to board and we're doing visuals and we're looking at videos and we're bringing in all different kinds of media so that you're able to understand the material and comprehend it rather than just memorize it. We've tried to memorize in nursing school. We know that doesn't work very well and it doesn't help you to really synthesize the material and to be able to utilize it when you get out into practice. So that's what we do differently here. We offer Skype individual sessions and group sessions, and we offer in-person Skype and group sessions as well. So we have a lot of different options for you, and we, like I said, we tutor in almost everything that you can imagine. If you have a need for it, we're going to find a way to get that to you. We have several different tutors. They are excellent in their field. So we have a couple of ICU nurses. We have a cardiovascular nurse, and so you're getting the best of the best in that field depending on what you're studying. So we're going to do a quick tour around and show you guys around really quickly, and then we're going to go ahead and get started on the Endo Live review. So follow me this way. This is our big tutoring room, so you can take a look around and kind of see what that looks like. So this is typically where we have sessions of anywhere from 2 people to 15 people at a time. We jump around a lot and we have visuals and we jump on the board and do different things in here. So this is where our main tutoring is done. You want to follow me down this way? This is an awesome Hall of Fame. So once students have graduated, they passed their NCLEX, they've come in with us and studied, and we've spent a lot of time together, they get their picture on the Wall of Fame, and it is really exciting for them. And so all these people that you see here have come through our program, have graduated, and we have more than this too, but we're trying to rebuild a new wall because we're running out of space. And so we have these students that get on the wall, they get their picture up here, and so when they come back and they visit or they come back for other services, then they get to see their picture on the wall, and it just represents how much time they spent here and how much energy and, just really how much they brought into nursing school, because it's hard. So this is a really big testament to what they're doing. So all these people are nurses and they're out caring for people places. So we're really proud of our Wall of Fame here. If you guys want to come back this way really quickly. This is a small tutoring room that we have, and so students are able to come, and there's textbooks here. We have almost every textbook that you guys could utilize in nursing school. You can use it while you're here, you can check them out, you can borrow them, so that way we can cut down on your cost for textbooks, because you guys know that's a little pricey. So we're here to kind of help you with that too. So students can come up here all day. We have free Wi-Fi, snacks, drinks, and they can come up and study in this room here. We also are just adding a new additional tutoring room in here. This is also kind of the student lounge for right now. So when they're waiting for their sessions or they just need a break to de-stress, they can come and sit and zen out a little bit in here. All right. Over here we have my office. And so I do a lot of my Skype sessions from in here. We have some other tutors that are now training on to do some Skype sessions too. I'm going to come on to the other side. Come on through this way. And this is our kitchen. We eat a lot here because we feel like if your body is nourished, then your brain's going to be nourished too. So we have free snacks. We've got drinks in here. So if you guys come up here, you can eat, drink, be merry, study, get smart, and learn all the things. All right. If you guys want to come back this way, over here we have CPR classes that we do. So So this is Ivy League CPR, and we do education classes over here too. So right now we have 7 CPR instructors. If you're an Ivy League student, you get 20% off of your CPR classes. So that's just one of the perks that we do for being an Ivy League student. Okay. We do other education classes over here. Right now we're doing a 12 Weeks to Wellness, which is also free and online for you guys. We do it on Facebook Live, and we bring in different people to talk about different issues that are pertinent to our community, such as how to deal with depression, and we do how to make healthy nutrition choices, and we do how to eat organic. And so we want to make sure that your body is staying healthy so that your mind can stay healthy and you guys can ace nursing school. So come on through this way and you guys can meet Marlena. So Marlena does a lot of different things here. She is a program director for our Center of Wellness. So we have yoga classes here. We have prenatal yoga for our pregnant mommies. We have mommy and baby yoga for those who have little ones. We are just starting Hatha yoga, and she also does holy yoga. So we do lots of different yoga classes to keep your mind, body, and spirit healthy so that you can maintain wellness. She also is doing a lot of admin for Ivy League Tutoring too, so if you guys call up here and have some questions about what we do here, you'll be talking to the beautiful Marlena. And this is the gorgeous little Wes. He's so cute. So he's an Ivy League baby. He hangs out here most of the time. We love having kiddos up here. So we have lots of different services that we offer. If you guys want to come back this way, we're almost ready to begin. We do have a little baby boutique in here. We are very big advocates of breastfeeding and lactation, so we do have a free support group that meets here once a week. They also have an online presence that's free, so if you guys want to, if you're a breastfeeding mom, you can join Latch and Chat. It is on Facebook. It is free. It's a community of moms that are just there to help you and support you, especially if you're breastfeeding in nursing school. That's a challenge. Kudos to you. That's amazing, and we want to support you best we can. So most of these little things are talking about little breastfeeding things. Like they have these, which are so super cute. So we have that, and then over here we have our nursing boutique. And so these are just cute little things for nursing school students. If you need to buy a gift for somebody, we've got Nursing School Survival Shot. We've got There's No Crying in Nursing School. If you're a big Grey's Anatomy fan, we have a You're My Person, or You're the Meredith to My Christina. We have all kinds of little cutesy things up in here for you guys to just stay healthy, well, happy. So if you guys want to come on back this way, we're going to go ahead and get started with our live review. All right, so if you guys can tell me kind of where you're coming from, I want to hear where you're tuning in from, what kind of nursing school that you're in, and then what your biggest concerns are with endocrinology, because this is a tough one. And I'll go ahead and get prepped and ready to get started.
Looks like we have Caro, sorry if I pronounced that wrong, from Bermuda.
Ooh, Bermuda, welcome. Glad you're joining us today.
We have Mandy from Belton, South Carolina.
Hi, Mandy, welcome. Glad you're joining us.
And we have Grace from Florida.
Hey, Grace. Welcome. And we have lots of Graces here. That's so funny because almost every semester I have several Graces, and they always make A's. So I think you're doing a really good job. You picked the right name.
We have Ashlyn from Bryan.
Hi, Ashlyn. Welcome. Oh, Bryan, are you an A&M student? Are we at Blinn?
Blinn.
Yeah, we're at Blinn. That is an awesome school. And we have several students that go there too, so welcome.
Jillian from Nashville, Tennessee.
Hey, oh, Jillian from Nashville. She got us some fun.
Tina from Monday, Texas.
What's up, everybody? I'm so glad you guys are joining us. And we have a big, giant surprise at the end of today's session. So you guys are going to want to make sure that you stay tuned for the entire time and hear what our big announcement is and our big opportunity for you guys to get more of what you see today. All right? So I'm going to go ahead and get started. We're going to start with Cushing's and Addison's disease, and how I typically do sessions is you will see that we do kind of the same format every single time, and that really helps you in your studying because it's a basic plan of care for your patient. I do this for every single disease process because it really helps you to synthesize and to get a pattern. So every single time I'm studying a disease process, I'm going to talk about the patho, the signs and symptoms, how do we diagnose it, what's the treatment as far as medications or procedures, and then what's my nursing care. If you can master the basics of this for every disease process, you're going to be doing really well in nursing school. This is a basic nursing plan of care. This is what we need to know, okay? So I'm going to try to go through this quickly, but Cushing's and Addison's requires a lot of oomph, you know, so it may take us a little while to get through it, all right? You guys are welcome to write your own charts. I probably will also post this at the end of the seminar. We can post this on the Facebook page. So if you guys are following us there, it would be a good idea. You can check later, and I'll go ahead and post the full chart. But it'd be good for you to be interactive. I'm going to ask questions during this session. I mean, there's nobody in here right now because I wanted it to be quiet and you guys be able to hear me, because our sessions get really exciting. But I want you guys to verbally answer me whenever I ask questions. If we can engage in some dialogue, even though we're not right in front of each other, it's really, really going to help you. So as I ask questions, try to synthesize that in your mind and think of what the answer would be and speak it back out to me, unless you're in a library and people think you're weird, so don't do that. Don't be the weird girl. Or boy, all right? So let's talk about Cushing's first, in case you can put some answers out too, just in case I'm like preaching to the quiet. All right, actually, let's talk about what these kind of disease processes look like first. So our endocrine system, what's its purpose? Well, its purpose is to create hormones. Its purpose is to create homeostasis in our body, and there's lots of different endocrine organs that do that. The one that we're talking about today is mainly going to be our adrenal glands here. The first thing that we usually see is the hypothalamus. He's the big bad boss of the brain, right? He is the mafia boss. He tells everybody what to do, and he's got all these plans behind him, and he is strategically planning out what needs to go where. But do mafia bosses ever do the dirty work themselves? Not typically, right? So the hypothalamus is going to send messages to the, does anybody know? The pituitary gland. The pituitary gland is in your brain too. So it's going to send some messages, these covert messages, to your pituitary gland. The pituitary gland is going to do the dirty work. It's either going to send out the hormones itself, or it's going to send out messages to the target organs to send out their own hormones. Okay? So that's kind of how our endocrine system is regulated. We have our hypothalamus, our pituitary, we have our adrenal glands, we have our pancreas. There's hormonal functions in almost every organ that we have. Your kidney produces hormone. Do you know what hormone it produces? Erythropoietin, all right? Your liver produces hormones, lots of them. So every organ is responsible for helping to maintain our endocrine function. We've got our thyroid, our parathyroid. So our bodies are constantly secreting hormones in order to keep us in balance. So today, mostly what we're going to be talking about is our adrenal glands. I love different colors of markers, so I'm going to be using that a lot. I think it kind of helps you to make a good visual. So with Cushing's and Addisons, does anybody know what two hormones are mainly involved in Cushing's and Addisons? The first biggest one that everybody always thinks of is cortisol, all right? So let's talk about cortisol. What is cortisol's job? Cortisol's job is our stress hormone, right? So its job is to be secreted by the adrenal glands whenever we have a stressful situation and we go into fight or flight. Why does your body need to go into fight or flight, or what does it do, okay? Fight or flight's job is to get us out of here, right? So if I'm just standing here at Ivy League Tutoring on just a normal day and all of a sudden a rabid dog comes in and is going to chase me, well, I'm going to be a little frightened and my body is going to say, you need to get moving and you need to run. So it's going to start making all of these different changes in my body in order to help me run away from the threat. All right, so what's going to happen to my blood sugar? It's going to increase, right? Because I'm about to have to run a long distance to get away from this creepy dog that's come in, all right? So it's going to up my blood sugar so that way I have more energy that I can use to run, okay? What's it going to do to my heart rate? It's going to go faster, right? How come? Because I'm nervous and I'm scared and my fight or flight, my cortisol and everything is soaring through me. It's helping me to get adrenaline and epinephrine so that I can have enough energy to move, all right? Obviously, I'm tired today, right? And so if a dog comes in, I need something to help me move instead of seeing a rabid dog come in and I go, all right, well, that's cool, and walk away, right? I need something to help me move. So my heart rate's going to go up, my blood pressure goes up, my blood sugar goes up. All these things are happening in order to help me get away from the threat, all right? The other hormone that is usually secreted by the adrenal glands is, don't look because I already wrote it, okay? Aldosterone, all right? And what is aldosterone's job? Does anybody know? Aldosterone's job. You guys can answer on here too. If you want to get some gold stars, I'll call you out if you get the right answers. If you guys want to type in the right answers, we'll call you out and give you some praise for that one. So aldosterone's job is to increase sodium in water, right? So if it increases sodium in water and we're increasing fluid, what does that do to my blood pressure? Across the board, always remember, more fluid, more pressure. Okay? So anytime you have more fluid volume, you're going to have more pressure, and that's going to cause you to have hypertension, right? So
Mandy had said aldosterone increases blood pressure.
Who said it?
Mandy.
Mandy, good job, Mandy. You got it. All right, so in Cushing's versus Addison's, in Cushing's disease, is our cortisol and aldosterone high, or is our cortisol and aldosterone low? Who can go the fastest? What you got? Nobody? All right. So in Cushing's, there may be a delay too, right? I'm sure you guys know this already. So in Cushing's, our levels are going to be increased, okay? So it's a high level of cortisol and a high level of aldosterone, all right? So let's talk about why that happens, all right? Does anybody know any reasons why we may get Cushing syndrome? All right, we know it's increased cortisol, right? Let's talk about patho. We know it's increased aldosterone, right? And that could be secondary to what? What would cause my adrenal glands to be overproducing, right? There's something that can grow that causes your hormones to go crazy. Does anybody know what that is? It's a tumor, okay? So if you get an adrenal tumor, okay, let me make sure this is erasable. Okay, if you get an adrenal tumor, okay, or where else could you get a tumor? We talked about this organ earlier, the pituitary. You get a pituitary tumor, and that could do it to you too, because that sends abnormal growth signals into whatever the places where there's a tumor, and that could make me oversecrete cortisol and aldosterone, all right? There's one other really big way that we can get Cushing syndrome, okay? And it is a Cushing-like syndrome. Not really exactly Cushing's, but they look the same. Does anybody know what drug class can cause Cushing-like syndrome? Come on, come on, come on. Nobody?
Steroid use. Darlene said steroid.
Darlene said steroid use. Good job, Darlene. So chronic or long-term corticosteroid use can cause Cushing-like syndrome, okay? It makes the adrenals very, very excited, and so they oversecrete cortisol and oversecrete aldosterone. So long-term steroid use will do that too, okay? All right, so we kind of know what's going to cause it. Now let's talk about the signs and symptoms. Anytime you're trying to remember signs and symptoms, you could memorize a giant list. You won't remember it, all right? So you have to understand the patho and what's going on here in order to understand signs and symptoms, right? All right, so I know something is happening to my adrenal glands that's making them overproduce these hormones. We already talked about cortisol and what it does. It's our fight or flight, right? And I've got an acronym for you guys today to remember this. All right, since this is the stress hormone, all right, this is going to say, your acronym is he is stressed out, okay? Because we are over-secreting these hormones all the time, all right? So here's what's going to happen. If you have an increase in aldosterone and an increase in cortisol, remember we said more fluid, more pressure. So is your blood pressure going to go up or down whenever you have an increase in these? It's going to go high, so you're going to get hypertension, right? So blood pressure is going to be high. What is our worst case scenario of hypertension? Why do we get so excited about hypertension? Does anybody know? No. All right, worst case scenario, if our blood pressure goes high, 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 we worry about the patient's risk for, Casey, do you know?
Stroke.
Stroke, yes, very nice work. All right, so we worry about risk of stroke. So you want to make sure that we're controlling that hypertension, but because they have increased aldosterone, we have extra fluid volume, they're going to have hypertension, all right? The second thing that we typically see, or other things that we see with this patient, this is so weird, so bear with me on this. They lose hair on their head, okay? So we get hair thinning on the head. So that's from, think about what people look like whenever they're stressed. I don't know if you guys have seen, there's a Facebook pictures that roll around every time we get a new president, and it shows what the president looked like when he came into office, and it shows what he looked like when he came out. And they're always missing hair, because why? Stress makes your hair fall out, right? So they get hair thinning on their head, but where do they grow hair? Anybody know? It also starts with an H, is the term for it. They lose hair on the head, grow hair on the face, the chest. It's called hirsutism. Okay, so they're going to lose hair on the head, grow hair on the body, all right? So you've got hypertension, hair thinning on head, and hirsutism, okay? The E stands for excessive sweating, right? Because what happens when you're in fight or flight and you're nervous and things are happening, you sweat a lot, don't you? So they have excessive sweating, which means that they're probably going to lose some fluid too, right? The I, there is a lot for I, all right? We know that aldosterone is a hormone, so if we're over-secreting hormones, this is a weird way to say it, but the men become ladies and the ladies become men. How does this happen and what do you mean? So some of the males will start to exhibit female-like characteristics. They can get gynecomastia, right, where they have enlarged breasts. They can get galactorrhea, where they actually start lactating. The women will get amenorrhea or infertility, okay? So amenorrhea means we don't have periods, or they may get dysmenorrhea, or they may get just irregular periods, right? Or they can actually become infertile, all right? They can also have insomnia, all right? Think about how you feel whenever you're stressed out. Do you sleep very well? Not so good, right? They get irregular periods. We talked about that one. All right, and you can put these S's in different places. I'm just putting them in this order for today. What happens to my blood sugar whenever I increase my cortisol, okay? We talked about cortisol being fight or flight, right? I know I'm about to have to get up and move, right? So what's going to happen to my blood sugar? I need a lot of it because I'm about to exert a lot of energy. So my blood sugar is going to go high. So your sugar is high, right? Are y'all with me? Yeah. Okay. So the second S is striae. Does anybody know what striae is? This goes with our next T, which is truncal obesity. Anybody want to explain to us how these two go together or what they are? Anybody know? I think there is a lag.
There's a lag.
Just a second. Okay. I'm going to write a couple more of these where you guys are giving me some explanations. Okay. All right. So
Darlene said stretch marks.
Darlene, you're
That's
on
right.
it today.
Darlene is on
Darlene's
it.
on it. So striae is stretch marks across the abdomen, which goes with our T, which is truncal obesity. So they get a very, very large abdomen and they get stretch marks all over the abdomen, all right? That's because whenever your sugar is really high, your body stores the excess as fat. So whenever we're really stressed, where do we tend to gain weight? Right around our belly, okay? Which is not cute for anybody, all right? So we got striae, we got truncal obesity, right? They get a round face, which is that moon facies, all right? You see this a lot with patients on chronic steroid use, right? They have fluid and retention, and so you might see the rounded off face, okay? They're also gonna get ecchymosis. Does anybody know? I bet Darlene does. Does anybody know what ecchymosis is? Anybody? Nope. Ecchymosis is bruising. So they get frequent bruising on their extremities. What these patients typically look like, if you look from the top to the bottom, I remember Cushing syndrome because they're really cushy, all right? They get a big cushy face, and we get a big buffalo hump, which we're going to talk about in a second. So they get a big cushion here. They have a big truncal obesity. They get a big cushion here. But their extremities are super thin, all right? So they have very skinny arms and legs, big belly, kind of big face. We call them an olive on a toothpick. It's not kind, but it's a way to remember it, okay? So they have very, very large central here and very, very skinny extremities. And the extremities are thin, and their skin gets kind of thin out here, and so they can have ecchymosis, which is easy bruising. The next S is for sodium and water retention. We've already talked about that one today. What caused the sodium and water retention? Does anybody remember? It was the increase, huh?
Jillian, Beverly, Darlene, Christopher, and Caitlin got the last one right.
Which
There's
one?
a lag.
Oh, there's a lag.
For
All right,
bruising.
ecchymosis?
Mhm.
Good job, guys. You guys are on it. So the sodium and water retention is because of the increase in aldosterone. Remember, aldosterone's job is to hold in sodium and water, so we're going to get sodium and water retention. All right? The next S is slow healing. Why would I have slow healing on this patient? If you think about it, we know that the patient had high sugar, and we know that our hyperglycemic patients do have altered wound healing, right? And so it may take them a lot longer to heal than other people, okay? All right, so the next one that we're going to see is erectile dysfunction. And this is sometimes pretty upsetting for people. We have a lot of fluid retention. We have our stress hormone going all the time. So if you think about it, if you have your fight or flight activated all the time, there's no change in real hormones, and there's no change in order to experience any kind of sexual pleasure. And so a lot of times we will have erectile dysfunction, which is really hard for some of our patients, all right? This next D here is called the dorsocervical hump. I've already talked about this today. So dorsocervical, back of the neck, we get a big hump, right? We said that they're very cushy. Yes?
The buffalo hump.
Buffalo hump, you got it. The O is for osteoporosis, all right? Why would these patients get osteoporosis? It goes back to our patho a little bit. So this is from our long-term steroid use. Remember, long-term steroid use can also destroy our bones. It can cause osteoporosis, all right? This U here is unable to stay awake. Now, that's kind of confusing because earlier we said insomnia. Okay, so but here's what happens. If you're really stressed acutely and something is going on, you're gonna have a very hard time sleeping, right? So they may have insomnia. But when you have a chronic stress response, think of what that does to your body. And you guys are in nursing school, so you know exactly what it does to your body. When you're in a chronic stress state, your body's in a constant fight or flight, and it eventually will just get exhausted. And so you'll experience severe fatigue whenever you've had chronic Cushing's disease. You've had it for a long time, and eventually your body is just tired, all right? The last T we've already talked about is thin extremities, all right? So we've got olive on a toothpick, we've got cushy. Those are ways to kind of remember what they look like, all right? So remember your acronym is he is stressed out. All right, if there's any questions on signs and symptoms, I need you guys to go ahead and post those now. We're gonna go ahead and go to diagnosis in the meantime. I'm going to quickly go over the different kinds of tests that we can do in order to diagnose. This is a little bit difficult to diagnose because there's Cushing's, there's Cushing-like syndrome, there's all different kinds of Cushing's. We can do our ACTH levels, which is another hormone that's secreted, so we can kind of run those. There isn't super direct cortisol level that we can draw. We can, but it's not incredibly accurate, so we have to do a couple of other different kinds of tests. Now, if you go back to patho, we know that this could be caused by an adrenal tumor. It could be caused by a pituitary tumor. So we're going to want to go ahead and do some imaging on those to make sure that we don't have a tumor that's causing it. Does anybody know what the test is that we usually do to rule out a tumor? Don't look at what I'm writing in sheets. Okay. Nobody? We're going to start off with an MRI or a CT. Typically, we're going to do an MRI, especially of the brain.
Yeah, and Beverly said MRI.
Beverly?
Or CAT scan. Yep.
Nice work. That's exactly right. You got both of them right. So the MRI of the brain, and you can know this for all of nursing school, MRIs usually catch more solid things. So if I'm looking for a tumor, if I'm looking for a mass, I'm typically going to do an MRI. If I'm looking for blood flow, then I'm typically going to do a CT. So for instance, if I'm looking for a brain tumor, I'm going to do an MRI. If I'm looking for a hemorrhage of the brain or a hemorrhagic stroke where there's liquid or fluid, I'm going to do a CT. That just typically tends to pick these things up better. So why would I do a CT of the adrenals? Well, a lot of times, either decreased blood flow or too much blood in the adrenals can cause Cushing-like syndrome too. So that's the reason why we're doing the MRI of the brain and the CT of the adrenals, okay? The other things that we can do is something called a dexamethasone suppression test. You guys have probably heard of this one before. Does anybody know what the dexamethasone suppression test does? So dexamethasone, y'all know what that drug is? Azone? No? Yes? Azones are steroids, right? So this one's sort of weird, huh? So dexamethasone is a steroid suppression test that we do. So in normal healthy patients, what we do is we have them come in typically in the evening time. We give them a dose of dexamethasone, and that normally will very temporarily decrease our cortisol levels. So I would draw them pre-level, give them a dose of dexamethasone, draw them again afterwards, all right, and see if there is a decrease. In Cushing's disease, you're constantly producing cortisol no matter what. So their cortisol levels would still be very elevated, okay? We can also do something called a salivary cortisol excretion test. And they actually test your spit for cortisol. Did you know you have stress hormones in your spit? It's crazy to me. All right. Do we have any questions so far? Everybody's crystal clear on this. You're going to nail this on your next test, right?
And whatever questions we don't get to in the live session, we'll go and comment after.
Yes, absolutely.
The
We
live
will get your questions answered. So absolutely we will do that. Just make sure you comment on this post. If you need to send a Facebook message, you can, but we're going to be quicker on the post. All right? All right, so that's how we're going to diagnose. We're going to do all these different kinds of things in order to diagnose, and then we're going to go on to the treatment. All right, so we've diagnosed our patient. They have all these signs and symptoms. What drugs am I going to be able to treat with? Well, there's really not a lot of drugs to decrease our cortisol. Unfortunately, we haven't gotten to that point yet. So if it's a pituitary tumor, we're going to remove that, either remove the tumor, or we're going to have to remove the whole pituitary, just kind of depending on what's going on with your patient. If we have to remove the whole pituitary, does anybody know what that term is called? It is called a hypophysectomy. So we may have to remove the pituitary, or at least, if nothing else, remove the tumor. The other thing that we can do is if the adrenal glands are causing us a hard time and there's a giant tumor that's infiltrated the adrenals, then of course we'll have to do an adrenalectomy. All right? We'll have to remove the adrenals. But the weird thing about this is that, and this happens in all endocrine conditions, one could always lead to the other and go back to the other one. So here's what would happen. This is what I mean by that. Cushing's, increase in cortisol, right? Our hormones are going crazy. So we take out your adrenals, and now you have no cortisol, so now you're going to have Addisons. In order to treat Addisons, we have to give you steroids so you could end up back with Cushing's, right? So endocrine is weird like that. So whenever they ask you questions on your exam that say, how do I know that the patient isn't getting better? How do I know things are worsening? Or what's the adverse effect? It's almost always the signs and symptoms from the opposite side. All right? All right, so these are some of the treatments that we can do, right? If it is from long-term steroid use, we may want to consider discontinuing the steroids. Now, what is a big consideration whenever you are going to have to discontinue steroids? Can we take them off today? Casey says, no, we can't. I see her head shaking. So, no, we can't rapidly take them off steroids or they have rebound symptoms, right? So if we're going to discontinue the steroids, if we find a way to do that, we want to make sure that we taper off slowly, okay? All right, so I want you guys to take about 30 seconds to think about what your nursing care for this patient is going to be. And anytime I get stuck on nursing care, I always go back to my signs and symptoms and think, how can I help these? Now, I may not be able to fix every single one, but there will be nursing considerations for almost every single one. So I want you guys, either whether you're in a group or whether you're by yourself, put your heads together really quickly and say, hey, this is my nursing plan of care. Daily weights, eyes and nose, boom, boom, boom. And I need you to give a rationale, all right? If you guys have anything that you're like, yeah, I know this is in my nursing plan of care, post it, and we'll give you a shout out as we're going through. And I'm going to write down a couple of things while you guys are going through too, just for the sake of time, okay? Anybody got anything?
Christopher says educate on diet.
Nice. What kind of diet, Christopher? What do you want for this patient?
He also said exercise to relieve stress.
Very nice. Good work.
Beverly says high protein, low fat. Christopher said low sugar.
Oh, okay.
Jillian, diuretic for fluid retention.
Good deal.
Ashlyn says exercise.
You guys are nailing it. Like, I'm very proud of you right now.
Mandy says diuretic. Beverly says teach FSBS.
FS what?
BS.
Finger stick blood sugar? Yeah? Anybody else? Anybody? Give me your top nursing diagnosis too for this patient. All right, so let's fix their problems. All right, we know we have increased cortisol. We know we have increased aldosterone. I can't really fix that unless I fix the underlying cause. All right, can I fix hypertension? Best I can, yes. We're going to give them antihypertension meds. And we talked about worst case scenario of hypertension, stroke. So they need to be on neurochecks and stroke precautions while their hypertension is really high. Now, if they're around, walking around and doing normal things and their blood pressure is under control, you don't have to walk around and follow them waiting for them to have a stroke because they're not going to. All right, that's only if it gets really high. All right, we talked about infertility, insomnia, irregular periods. We really can't fix the infertility and the irregular periods until we fix the underlying cause. What about insomnia, right? We want to do frequent rest periods and good sleep hygiene, right? So we want to make sure that they turn off all electronics and that they're sleeping in full dark, right? So we do sleep hygiene. You guys know what that looks like, right? All right, let's fix sugar high. How do we fix sugar high? Well, somebody already said finger sticks, blood sugar. They may have a need for insulin temporarily, so we may need to give them insulin as needed for a short period of time until we get the underlying cause fixed. Christopher said something about diet, and you guys are all kind of right with the diet. We want low fat because we are kind of overweight and we're having a weight issue because we're depositing fat. We also want low sodium, somebody said that, because you are retaining sodium in water. Yeah? We need to do proper wound care. How can we need to do wound care? And teach them about looking at their body for wounds. Okay? So we talked earlier about because they have high sugar, they have slow healing, we need to watch for wounds and make sure that we take care of those pretty adequately. We do want them to exercise. It's not only good for their weight, but it's also good for their psyche. It's good for stress relief. So we've got to find some ways that can relieve stress in these patients since we're in a chronic stress state. I wrote down bone scan or bone density test. Why did we write that? Because if you remember back over here, one of the signs and symptoms that we have is a possible osteoporosis. So some non-weight-bearing activities, some weight-bearing activities, and we want to get the exercise, get them moving, and watch those bones, all right? Body image issues are a really big deal.
That's what Beverly said. She said risk of infection / our ... body image.
Yes, and you put them in the right order, right? So this patient is at risk for infection because we have chronic fight or flight and we're moving all of the time, and so we don't have that stress response when we're sick that kicks in and helps us to get better because your stress response is high all the time. So these patients are always at risk for infection. Secondary, yes, I would put body image because this is hard, right? They get acne sometimes too, and you have weight gain and your body looks different than it normally does, so that can be a real stress for people. I also put eyes and nose and daily weight because we are retaining fluid, right? And our best indicator of fluid volume all the time is,
Weight.
Casey, do the honors.
Weight.
Daily weight, always. In
Water
any
weight.
nursing exam, okay? There are very few exceptions, which I will point out if you guys keep tuning in. The most important thing that you will see is daily weights. That's our best indicator of fluid volume, right? Eyes and nose can wax and wane and do all kinds of wanky weird things, but our daily weight's going to give us the best indicator of fluid volume. All right. What questions do you guys have on Cushing's? We're moving way slower than I thought, and I feel like I'm moving really fast, but we may only be able to cover Cushing's and Addison's today. We may have to save the other ones for another day. But let me know if there's any questions on Cushing's, and we're about to move into Addison's. All right, I'm going to give you guys about 15 seconds to kind of jot down some things if you have some questions, and we'll hit those before we go over to Addison's.
Some of the other nursing care plans, Joanne Lenzo, sorry if I said that wrong, was fluid volume excess and skin integrity.
Yes, excellent. So fluid volume excess, we need to watch for what kind of signs and symptoms, right? If they have fluid volume excess, right, what happens to our pulses? We've got tons of fluid in there, right? So they may have bounding pulses. What happens here? Jugular venous distension. What would we listen for in the lungs? Crackles, because we've got fluid backing up. So it's an excellent one. What was the other one? Fluid volume excess and... Would it go too far?
It's skin integrity.
Skin integrity, yes. Because of the wounds, and we have ecchymosis, and we have thin skin in our extremities. So absolutely skin integrity. You guys are nailing this.
Christopher said difficulty breathing is one thing that you'd look for too.
Because why? Because we have fluid volume excess is one of the reasons, right? And so whenever we have backup, yes, they can start having trouble breathing. Agreed?
Beverly said I guess, I don't know if it's supposed to say, if there is no tumor, what would we advocate to test wise?
If there's no tumor, then we'll do the dexamethasone suppression test or the salivary cortisol secretion test. All right. So we're going to rule out tumor first because that would be the obvious cause. And then we're going to start to do some other things here too. And if they're on long-term steroid use, you would know, right? Good question. Anybody else got questions before we move on to Addison's? How are we doing on time? What time is it?
12:40.
Oh, wow. Okay. All right, so we will hit Addison's, and then we'll save the rest of them for another day. But we're going to do another one next week, so you guys can hang tight. And also, before we leave today, I want you guys to already be starting to think, because our live review for next week is going to be voted on by you guys. I want you to let us know what you want to see. Either you can pick a body system or a couple of disease processes, and the live review we do next week will be what you guys pick. We want to hear what you guys want to hear about. All right. All right, so let's go on to Addison's disease. So we talked about Cushing's disease, and it's a disease of the adrenals or the pituitary, or we got too much steroids, and it causes increased fight or flight and increased hormones, and so we're moving all the time, so it's causing everything to be very, very excited. Well, Addison's disease is the opposite, right? And so Addison's disease is going to be a lack of cortisol or lack of aldosterone, all right? So we know what cortisol does. We know what aldosterone does. Now that we've covered that, now we should be able to kind of formulate a plan of care for what Addison's looks like, okay? Tell me some things, or do you guys know any reasons why we may have Addison's disease? Because there's a lot of reasons behind them, and they're very different. Some of them are the same from Cushing's, and some of them are different. So you guys let me know what you think. Don't look at what I'm writing. Okay. Anybody have anything? There was a famous person that we thought had this, right? Does anybody know who the famous person that had this is? Anybody know?
Drum roll.
Yeah, come on, come on. Nobody got nothing.
There's a long lag.
Okay. I was like, I know these people are on top of it, so I know you guys have some thoughts here.
Jennifer Rios wants you to come teach at her school.
All right, let's go, girl. Where do you live? Yeah, I know. It's going to take a second. Let me know. You can just pop in whenever you're ready. All right. So a couple different things we have for Addison's disease. We know it's low cortisol. We know it's low aldosterone. So why would that cause a problem? Well, the reason it would cause a problem is because I don't have any stress hormone at all, right? So whenever my body needs to increase my blood pressure, needs to increase my heart rate, and needs more blood sugar because I need to run or move or fight disease, it doesn't have that.
Miriam got it right. It was JFK.
Yeah, JFK. Very good, Miriam. Nice work.
And Jennifer goes to school in Dallas.
Jennifer. Oh, I have lots of students from Dallas. You should Skype in. All right. All right. So we have Addison's disease, low cortisol, low aldosterone. So let's talk about some things. We already talked about our endocrine glands, right? Pituitary was one of them, adrenals are the other one. So if you have a tumor on either of those, that can cause a problem, either too much cortisol or too little cortisol. So that's why you're going to see it on either side. So pituitary tumor, adrenal tumor can cause either too much or not enough. If the tumor is pushing on the adrenals and it can't secrete anything, it would cause low. If it's growing on the adrenals and it's causing, remember, cancer has lots of growth signals that it sends, so it may overproduce. That's why you're going to see both sides. The other thing that can happen is if you're bleeding into the adrenals, so you have some kind of condition where you're bleeding in, okay, what's wrong?
Oh, no, I was just saying bleeding in.
I know, it sounds gross, doesn't it? Bleeding into your adrenals sounds awful. And so if that can happen, then that's going to, basically the blood is going to take the spot where the hormones would be secreted. The other thing that's unique to Addison's is if you have TB, HIV, or a severe fungal infection, it can affect your stress hormones because your body is in stress and it can deplete you of those hormones. So anytime we have a patient that we consider Addison's disease, we need to do tests for TB, HIV, and fungal infections.
Stacy nailed the fungal infections.
Yeah, girl. Nice work. All right, so TB, how would we do a test for that? We usually do a PPD first. And then if the PPD is positive, then we do a chest x-ray. And then if the chest x-ray is positive, then we do a, Casey already gave us the nasty, disgusting sound of the sputum culture. So we're going to do sputum culture to be definitive. All right, HIV, we're going to diagnose with, anybody know? An immunoassay, and we're going to follow it up with a Western blot. And then we're going to test for different kinds of fungal infections. All right, probably do a blood culture, probably do some other things too. The other thing that can cause Addison's is autoimmune. Either autoimmune diseases can cause you to go into Addison's, or Addison's can be autoimmune. And so if you have these autoimmune diseases, we know that your body is attacking itself. And when your body is attacking itself, it can attack your adrenals too, causing you not to produce any cortisol or aldosterone. All right? So let's move on to signs and symptoms. So I did a little acronym for you for this one too, okay? Because Addison, I always think of Addison, and you'll see why in a second, but Addison, and don't get offended if you're in a sorority, okay? This is just to help students remember. So Addison is a sorority girl, and like she doesn't have any cortisol because she cannot even deal with stress because she doesn't have any cortisol to do that. So she cannot even deal. And that is your acronym for today, okay? So I'm really good at that too, and I wasn't in a sorority. So don't get mad at me if you're in a sorority, all right? It's just a joke. All right, so your acronym is going to be she cannot even deal. Okay? All right, so let's talk about some signs and symptoms that would happen if you have absolutely no cortisol whatsoever. And I'm going to talk about kind of overall what your body looks like, and then we'll get a little bit more into the specifics. So if your body has nothing to do with stress, all right, and your normal fight or flight makes your heart rate go high, then your heart rate may not go high. You may get a little bit of bradycardia, which would impact our cardiac output, right? If we don't have anything to raise our blood pressure, then we may get hypotension, right? So you have times of stress, but you're not able to increase it like you need to, so your blood pressure is going to go down. What's a worst case scenario of decreased cardiac output and hypotension? Why do we get so nervous? We said we get nervous about hypertension because we're going to stroke. What's a worst case scenario of hypotension? And if you get big gold stars if you get this one. Why do we worry about low blood pressure? I'm going to start writing these while you guys are talking.
Mandy says syncope.
Okay, why would they get syncope?
Christopher said pass out.
Okay, they may pass out, but you guys aren't taking it far enough. All right, so worst case scenario is not that I faint. What is my blood pressure's job? What is it? Why do I need pressure? What am I trying to get pressure to? Come on, y'all.
Daniel said shock.
Ah, okay.
Ashlyn said die.
Yes, shock and death. That's what I always say. Like, if you have to, like, do a throwback, be like, death, you know? Or if I ask you a sign and symptom and you're just not sure, always pick malaise. Because everybody knows, like, no matter what disease you have malaise, you feel bad, okay? So this patient can have such significant hypotension. The worst case scenario with hypotension is shock, which leads to MODS. Does anybody know what MODS is?
What everybody dies from.
Come on, y'all. What does MODS stand for? I think we're just waiting, right?
Mm-hmm.
Nothing?
Oh, Amber's close. Multiorgan.
Yes, yes.
Anna
What's
says
there?
Multi-organ dysfunction.
You got it. All right, multi-organ dysfunction syndrome. So what happens when you go into shock? When you hear the word shock, I mean, I heard that all through nursing school, and I probably couldn't have told you exactly what it meant. I knew close to death, right? So what happens with hypotension is your pressure is so low, and that usually means your fluid volume is low or your fluid volume is not in the vessels. So if my fluid volume is low, that sends your body into a message, and it says, you only have this amount of fluid and this amount of pressure. You better stick it to the right parts, all right? So it starts to prioritize. So where does it shunt away from first? It's going to shunt blood away from your extremities into your core, because I need my brain and my heart and my lungs and my gut and my kidneys, and I need all these organs to survive. I could survive without my arms and legs. It would be a struggle, but I could do it, all right? So it's going to start shunting away from that first. Then if it still only has a little bit of fluid volume and that blood pressure is 90/60, 80/50, and it starts to get really low, it sends a signal to me, oh, holy crap, like I need you to shunt to only the most essential things so that I can give perfusion to only the most essential organs, right? So what it will do is start, all of a sudden your organs are going to start dying because it has to prioritize. What's the first organ that always dies first? Red flag, gold star for somebody who gets this one right. Anybody? When you go into shock, what organ takes a hit first? Nobody?
We just gotta wait because
it's
the
that
lag,
lag,
but
isn't it? That's frustrating.
because I believe they're gonna get it.
I know they're gonna get it. They've been on it today. Like, I'm really impressed. You guys brought it.
Mandy says kidneys.
Kidneys, you got it, Mandy. That's right. So the kidneys always take a hit first. They're really kind of bullies to the kidneys. The kidneys can go through a lot and still survive, so that your body will shunt fluid away from the kidneys first. And then all of a sudden, in order, your organ systems are going to die because they're not getting any pressure, they're not getting any fluid, they're not getting any perfusion because there's no blood flow there in order to perfuse them, so they'll go into MODS. So that's kind of what we're looking at, and I'm not saying every patient who has Addison's is going to go into MODS, but I'm saying that that's kind of the progression that we're looking at and why it's so important for them to have cortisol and aldosterone. Because remember, aldosterone does sodium and water retention. If I don't have aldosterone, I'm going to be dumping fluid, leaving me with very little fluid inside. Less fluid, less pressure. Remember, we had that concept earlier with more fluid, more pressure, less fluid, less pressure. Y'all with me? All right, so let's start going through. I'm almost done writing these. Let's start going through the signs and symptoms, and you guys can explain to me why we would have these signs and symptoms, okay? All right, so patients lacking cortisol, patients lacking aldosterone, syncope. You guys already mentioned this earlier. So if your blood pressure gets really low, how does it make you feel? You get very dizzy and lightheaded because it's having to pull some blood flow from your brain, right? So they are at risk for injury here, right? That would be a good nursing diagnosis for us.
Somebody's earlier said risk for falls would be a good.
Yes, risk for falls is excellent. Risk for injury, risk for falls, absolutely. Hyperpigmented skin. So remember, Addison is our sorority girl, and so she ends up being like very thin, and she's got tan skin, and she can't deal with stress. I know I'm gonna get hated on for this. Okay, so they get hyperpigmented or tan skin, which is why JFK always looked so glowy, even though he lived up north. Okay, the E stands for extreme fatigue. Why would they be tired? Well, if you don't have any cortisol to kind of give you the get up and go, your fight or flight, you're going to be exhausted all the time. Plus, your blood pressure is low, which is going to make you tired. Now, there's a couple of these that I want to say are only going to be if you go into crisis, okay? So there is an Addisonian crisis. That means that this is like you're in a time of stress or injury, and these get so low to where it could actually kill you, all right? So I'm going to mark the ones with a C that are going to end up being in crisis, all right? So I wrote up here circulatory collapse. So we could have hypotension so severe because they're peeing out a lot and getting rid of fluid because they don't have aldosterone, right? Remember, aldosterone's job holds in fluid. If we don't have any, they're letting out fluid. So they may end up going into full circulatory collapse and coding or going into hypovolemic shock. That could happen in an Addisonian crisis, all right? Appetite suppression is the other one, right? We know that when we get stressed, what do? Eat, okay? So if they're not having any stress hormone, then they don't feel like they have a need to eat. Right? They don't feel like there's any stress there. They don't need any energy to get up and run somewhere. So they have appetite suppression, which is what's going to give us our weight loss. All right? The N here is for needing salt. Why would they need salt? Well, they lack aldosterone, right? And aldosterone holds in sodium and water. So if they're letting all of that out, their sodium goes out, okay? And so we may need some salt, okay? Not intentional weight loss, so they're not trying to lose weight, but if a patient comes in and says they've had significant weight loss and they have not been meaning to, I don't know who in the world this would ever happen to. Like, I've been waiting for this to happen for a long time and it will never happen for me. But if it does happen and there's non-intentional weight loss, that always red flags us, because if you remember, non-intentional weight loss can also be a sign and symptom of TB or HIV, which could be precipitating your Addisons, right? All right, the O stands for obtuse level of consciousness, and that can only happen in a crisis, right? And so if your patient has full circulatory collapse and they're going into shock, their level of consciousness may be altered. T stands for tiredness, right? We're fatigued, we're tired because we don't have anything to get us up and moving, all right? The E, I'm gonna put a C on this one too. E stands for excessive temperature, all right? And so sometimes whenever they go into crisis, your body is in full out, like, a attack mode, something is attacking it, but you don't have anything to deal with it, so it will increase your temperature. But remember, if you increase your temperature, you're also going to have compensatory fluid loss, because your metabolism is running higher and your body is heated higher, and so that's going to require much more of your body. So that's another way we could be losing fluid. Sometimes whenever they go into crisis, because there's something that is attacking your body, right? Like whether that be an illness or really stressful that you guys are going to take a nursing school exam, right? And that produces a lot of stress. So when they are presented with stress, okay, they're gonna puke, right? They're gonna vomit, okay, because they don't have anything to do with that stress. Another crisis symptom, and you guys need to know this whenever you have tests, is that they start saying they have excessive back pain, and I'm not sure exactly why they have that, but anytime on a nursing exam in the history of forever, if it says excessive back pain, that's going to be your answer, okay? Excessive anything is never good, but if you think about it, that's also a sign and symptom of a AAA that has ruptured, an abdominal aortic aneurysm, severe back pain. So if you see that, that should clue you in, I really need to look at this answer. All right. They can also get nausea, dehydration, because we're peeing out copious amounts of things because I don't have anything to hold water in. Okay. If I'm getting rid of my salt, all right. So because I don't have aldosterone, right, and aldosterone's job is to hold in sodium and water, and I'm getting rid of the salt, what's my potassium going to do?
Beverly's been saying hyperkalemia.
Yeah, she's been wanting me to say it.
She's like, say it.
Yeah, so there it is. All right, so we get excess potassium. So sodium and potassium are always going to go on a seesaw. One goes up, the other goes down. All right, so if my sodium level is very, very low, then by proxy, we know that our potassium level is going to be high. All right, so if my potassium level is high, there are 6 different antidotes for hyperkalemia. Start rattling them off to me. You have 15 seconds.
And just so y'all know, we're going to post the picture of this chart later. It's kind of hard to see on the video right now, but we're going to post it on our Facebook page when we're done with this session. Daniel, just so you know, you'll know which dates and times the live reviews will be because we'll post them on our Facebook on Ivy League Tutoring. Mm-hmm. And on this post, you can go ahead and start throwing out which topic you'd like for next week, because we are going to have one next week as well.
So make sure you're following the Facebook page, because we will create another event for that, or we may just change this event. I don't know. We'll kind of see what that looks like, but we'll definitely put an event up there so you guys know what date, what time, and what we're going to be covering. Okay? All right. Did anybody give me hyperkalemia treatment?
Anna and Beverly said Kxalate.
All right. So I'm not going to write these up there because for the sake of time. But yes,
Beverly
Kxalate is our true antidote. It's a medication that we give. Polystyrene sodium is what it's really called, and that is a true antidote for hyperkalemia. What else you guys got?
Beverly and Daniel said insulin.
Okay, yes, insulin. Now be cautious with insulin. If you have a non-diabetic patient, you need to give insulin plus D50, otherwise you're going to cause them to go into hypoglycemia. If it is a diabetic patient, then just insulin. And the reason being, there is a pump for that too, okay? So if your potassium level is high, all right, so what's going to happen inside the cells here, if my potassium is high and you give insulin, it's going to rush in and force those out. They're going to go back and forth, okay? So if I have high potassium, right, and I give insulin, it's going to do this, right? Just watch your diabetic patients. All right, so we've said Kxalate. We've said insulin. What else?
Dialysis.
Dialysis, yes. So if we can't get it under control with medications and giving things, then dialysis is going to take all your blood out, clean it of all the potassium and all kinds of nasty stuff, and then give it back to them nice and clean without all that potassium. That's 3. What else you guys got?
Candace says you need an ABG.
You are going to need ABGs, absolutely. Yes, you will. What are our other antidotes? We got 3 left. Nobody? Think about what goes on your seesaws. It's like a brief intro into fluid and electrolytes, okay? We talked about sodium and potassium already, right? We did that pump. So if your potassium level is high, okay, then I know probably that my sodium level is low because we said they needed salt, right? So what do I want to give them? Something sodium, right? If I gave them sodium bicarb, right? So potassium's high, sodium's low. You're going to give them sodium bicarb and we should do this. All right, and that will also help me a little bit with the needing salt. Okay, so that's 4. What else goes on a seesaw with potassium in the heart? Does anybody know? It's electrolyte. So pumps we've talked about before. Potassium and insulin go on a seesaw, right? Or on a pump. Potassium and sodium go on a pump in the kidneys. What goes on a seesaw pump in the heart?
Calcium.
Yes! Who said?
Beverly.
Beverly, you're an all-star today, man.
And Christopher said calcium
all right,
as well.
nice. So Christopher's on it today, too. So calcium would be the other one. So we want to give calcium gluconate would be another one. Our number 6 is a rando weird one, and it works on some people, is albuterol, which is so weird. Okay, but they can sometimes use that, and that will help to bring down the potassium levels. All right, so this patient, she cannot even deal, all right? So now we need to diagnose. She's got all these signs and symptoms. She's tired. She's fluid volume deficit. She is just, bleh, right? We're having a really, really hard time. So we need to diagnose this. We can do this with a couple of things. I'm not going to go tons into this, but I do want to mention it. ACTH stimulation test, we can do that. We talked about ACTH earlier when we draw ACTH levels because those are going to correspond with our adrenals, right? Since we know that it can be caused by a tumor, we're also going to do the CT of the adrenals and the MRI of the pituitary, okay? And then we said that it could also be caused by TB, HIV, fungal infections, so we need to check for those. We're going to do the test for TB, the test for HIV, and then we're going to look for fungals, right? Are you guys with me? Okay, so we're going to screen for different diseases. Since this can also have an autoimmune function or an autoimmune component, what is the generic blood test that we can draw that tells us that we have an autoimmune disorder, but it doesn't tell us exactly which one? Anybody? Yes, no, maybe so. No?
Beverly said BUN related to dehydration.
Okay, so we could do a BUN. I agree with that. What else? It's a test for autoimmune. What do we got? Starts with an A. No, we struggling on this one. Where'd Christopher at? All right, so what we're going to do is called an ANA. It's an anti-nuclear antibody, okay? And so that can give us an idea if we have an autoimmune component. It just tells us that we have an autoimmune disorder, but it doesn't tell us exactly where that or which autoimmune disorder that it is. But that can be helpful in helping us to diagnose.
Chasey said ANA.
Oh, Chasey?
Mm-hmm.
Oh, I know her. She's smart.
Aww.
That's my friend. All right. So Addisons, we got decreased cortisol, decreased aldosterone. So what would the treatment look like for this patient? We don't have hormones. We're going to have to give him some hormones. All right, so treatment is going to be lifelong corticosteroid use. Okay? So the corticosteroids are hormones, right? Yeah? Lifelong corticosteroid use. All right. But now what happens is that I'm giving them these hormones, right? Then I'm giving chronic steroids that could cause them to go into chronic steroid use, Cushing's. So we have to watch them for signs and symptoms of the other side. All right. I want you guys to give me a nursing plan of care. You have 30 seconds to develop a full plan of care for this patient and give me your nursing diagnosis and priority. 30 seconds. That's plenty of time to create a full nursing plan of care and give me some nursing diagnosis. Hit me with your best shot.
Fire away.
Oh, I knew that was coming. We need some music in the lulls so we can drop it like it's hot. Oh, that's good.
Christopher said, I can't think. Come on, bro.
Come on, we're almost there.
Beverly says they need consistent monitoring for exacerbation, now signs and symptoms of Cushing's.
Yes, very good. What else we got? Anybody else? All right, let's talk about it really quick. I'm gonna write all of them whenever we're done because we're already out of time, but let's just keep chatting because this is sort of fun and you guys are doing really good. Okay. So, different things that they're going to need. So, remember whenever we're looking at our nursing plan of care, if you get stuck, always go back to your signs and symptoms. All right? So, this patient obviously is very fluid volume deficit. We know that. So, we need to give them some IV fluids. We also know that they need salt, right? So, we're going to have to give some kind of sodium. Remember, you can't push sodium. We don't do anything like that. But we can do a high salt diet, right? And speaking
That's
of
what
diets,
Ashlyn said.
Yeah, who?
Way to go, Ashlyn.
Ashlyn, nice work, Ashlyn. And so in this patient, their diet is going to be very specific because they need salt, right? They have too much potassium. They're underweight, right? So what are we going to do for them? All right, so we're going to do a high protein, high salt, low potassium diet. Yeah? Small frequent meals, increase our calories, okay? We don't want them to have very many carbs. We kind of do a lower carb and more protein. And the reason that we would do that is because they do get hypoglycemia. And so if you're giving them a lot of carbs, they're going to burn that sugar rather quickly because they don't have any cortisol to help them. So we want to give them more calories and protein to sustain them over a longer period of time rather than just giving a bunch of simple sugars all at once. All right? So we're going to do, this patient is obviously very exhausted. They get tired because they can't deal with stress very well. So we need frequent rest periods and we need to make sure that the patient is getting adequate sleep, right? Fluid volume is a big issue. So let's talk about fluid volumes. We need to be monitoring their blood pressure, right? What's the best indicator of fluid volume? If y'all don't know this now. Okay, so we're going to do a daily weight since that's our best indicator of fluid volume. And we're going to do Addisons too. That's really important. All right. We're going to monitor, say, BP, Addisons, daily weights, give them fluids. Is there anything I missed? Watch for that hypotension, right? We may need a salt supplement if they're really, really deficient. If they're very hyponatremic, we may need a salt supplement. So we have to watch that too. If we know that the patient has hyperkalemia or we're getting to that point, what do we need to do? What's a worst case scenario of hyperkalemia? Am I helping? Is it happening? Dysrhythmias, right? So we need to do an EKG on that patient, all right? So we're treating the low blood pressure with fluids. If just the fluids don't fix it, what's our next thing that we do in addition to fluids? So we have these empty vessels, right? All right, empty vessels. We're going to fill them up with fluid, right? But then your vessels may be kind of relaxed. So we may also want to give vasopressors. And the vasopressors are going to, right? And they're going to kind of bring the vessels in so that can maintain a blood pressure so that we don't have poor perfusion or MODS, okay? All right, so we're fixing this patient. So we fixed their fluid and we have fixed their electrolyte imbalance and we're giving them all of these nutrients in small frequent meals with lots of calories. This patient, if we don't have any cortisol, right, then we're not having a lot of blood sugar, right? Cortisol helps to increase our blood sugar in times of stress. So they can actually be very hypoglycemic. So we need to have simple sugars on hand, be checking our blood sugar very often, all right? And monitoring blood sugar for hypoglycemia, because that could be a priority. I mean, they could die very quickly from hypoglycemia, right? All right, so we, because we are so hyponatremic, all right? Now we talked about electrolytes. We know that salt and potassium are maintained by the kidneys, right? But whenever you have sodium abnormalities like hypo or hypernatremia, the signs and symptoms are always brain symptoms, all right? Headache, coma, confusion, seizure, death, all right? So sodium is maintained or managed or balanced in the kidneys, but you'll see signs and symptoms of brain. So we need to be doing neurochecks and put them on seizure precautions because patients that have hyponatremia can get seizures, right? So, all right, so here's what we've done so far. IV fluids, adequate rest, eyes and nose, daily weight, salt supplements if we need to, high salt diet, low carb, high protein, high sodium, monitor our blood sugars, have simple sugars on hand, seizure precautions, neurochecks, monitor electrolytes, watch for signs and symptoms of shock because they can go into circulatory collapse. What vitals will you see change whenever you're in shock?
Oh, I know they got it. Just give them some time.
It's coming. It's coming. What y'all got?
Ashlyn and Anna said blood pressure, but what does the blood
what
pressure
happens to your
do?
blood pressure? Blood pressure does something.
But what?
But what?
Christopher said low blood pressure.
All right, so you get low blood pressure, and then how does your body compensate?
High pulse Christopher is on it.
Oh, yeah. All right, so we get hypotension, tachycardia would lead me to believe my patient's going into hypovolemic shock. I need to give them fluids, pressors, and I think Darlene said check those kidneys, because remember, kidneys are going to be the first to go. So BUN and creatinine are really important to monitor in Addisons, because if their BUN and creatinine are good, that tells me I have perfusion to my kidneys and I'm not in shock. Yeah? All right. So that is the plan of care for Addisons. I'm going to finish this in a few minutes, and we're going to post this whole thing for you guys so you can see it. Remember your signs and symptoms. Cushing's, he is stressed out. Addison's, she cannot even deal, okay? And that will help you to remember signs and symptoms, and you can always build your nursing care off of signs and symptoms. Just fix the problem, all right? I'm going to take about, I know we're out of time, but I have extra time, so let's hang out. Give me your questions. So hit me with your best shot. Well, I'll do my best to answer any kind of questions that you guys have. I'm actually going to sit down for 1 second. So I'm going to let the questions come in, and then we'll answer our questions best we can for you. About endocrine, or you guys can already start posting what you want to see next week.
All right, I'll go ahead and show you this board real quick. But we're going to post a picture at the end.
Just in case y'all missed anything, if you're making your own chart, you want to jot it down, you can do that now.
All on you.
Oh, hey. Oh.
Hey.
What's up? Okay. I'm just drinking out of my amber cup.
Y'all are welcome, guys. A lot of people are like, thanks. Y'all did amazing today.
Yeah, y'all were really good. You really brought it today.
On it.
Really proud of you guys. So hit me with any questions, or you guys can tell me which one I see next week. So if y'all don't pick anything, I'm picking something, and it's going to be weird. So pick something cool, and that way we can cover that for next week.
Christopher said psychology.
Psychology. Okay, just like all
What,
of it.
like just broad psychology, or is there anything in specific that you would like to know?
Schizophrenia gives you a hard time, or bipolar, or differentiating between all the personality disorders.
Therapeutic communication?
Yeah,
That's a
people
tough
struggle
one.
with that. That's a struggle just in life.
Anna says cardiac.
Cardiac, okay. What kind of cardiac? Like MI, congestive heart failure? What do you want to see? Tell me what you want.
Oh, we got 2 for cardiac.
2 for cardiac. I figured that was coming. All right. Anything else?
Christopher said drugs. Like what kind? Prescription,
drugs. Probably
street.
psychology, street drugs. We be talking about some cocaine in here. Okay.
All right.
Do a little farm. We'll throw some farm in. All right, guys. So we're gonna go ahead and sign off for today. You guys can comment in the sections if there's anything that we missed. You can post your questions. You can let us know what you want to do for next week. And then in probably the next, I'd say 30 minutes, we're about to post like a really big, cool announcement thing for some really cool stuff for next week. So you want to tune into that, because you will have an opportunity to win some free stuff and to get free things, which feels good.
I love free.
So make sure that you're following the page, because we're about to post the event. We'll post the event for next week in the next 30 minutes or so, and then our big announcement will come out. So I'm glad you guys got to join us today. You guys did great. You were awesome. You were smart. Hope that you have learned all the things today, and we will see you guys next week.
It looks like it's going to be cardiac.
Okay.
All right.
There it is.
Bye, guys.
See y'all next time.